against CD19, that is blinatumomab, is being used in a patient, and how can we use how to gate the B cells in such cases, MRD analysis. So the options were CD19 gating, CD22 gating, CD34 gating, and CD45 gating. So many of you have answered CD22 gating. We have to see why CD22 gating is the right answer is or it is the wrong answer. So whenever we are analyzing a case of BMRD, then we have to analyze the 19 positive cells that are the CD19 positive blasts. So basically from the BMRD, we have to analyze if the residual blasts are actually abnormal B blasts or those are hematogones. So we can differentiate between those two with the help of LAIP markers, which we'll see. But before knowing the uh, gating strategy, we should know what is blinatumomab, how a blinatumomab works. So basically, a blinatumomab is a bispecific T cell engager, that is BiTE, that binds to both T cells and the B cells. So basically, this allows the T cells to identify and destroy the cancer cells by bringing them closer together. So basically, these T cells will be destroying the B cells and the CD19 positive cells. So blinatumomab usually is used as a bridging therapy in cases of BALLs, which is used as a bridging therapy in pre-transplant workup of a patient. So once the blinatumomab is given, MRD analysis is done, and after the MRD negativity is there, the patient can be posted for a transplant. So whenever we give a patient blinatumomab, then the 19 positive receptors will be gone. So if a 19 positive receptor is gone in a B cell, then how can we identify the B cells? 19 is the most specific B lineage marker, or it is the most potent B cell marker, lineage specific marker. So if 19 is gone, how can we identify the B cells? So we can identify the B cells with the help of markers like CD22, CD20, CD24. So these are the markers which can help us in using a primary gating strategy in BLL MRDs. So basically, whenever we are analyzing a case of BLL MRD, first we have a 45 versus site scatter where we can see the granulocytes, monocytes, lymphocytes, and progenitors. So basically, in the progenitors, we have to analyze if the progenitors are having any abnormal B blast, or hematogones are there, or myeloid blasts are there. So in the progenitors, we get the 45 MNCs or the 38 positive low site scatter cells under 19 and 45. So the cells with 19 positivity and 45 positivity are analyzed with the further markers. So basically, this is the gate we usually place with a bright 19 positivity, which has to be analyzed in BLL MRD cases. So 19 negative cases not is not needed to be analyzed, but 19 positive cases have to be analyzed. Positive cells have to be analyzed in BMRD cases. But when there is no 19, when the patient has received a CD19 anti-CD19 therapy, that is the blinatumomab, then we'll have to gate the blasts or the abnormal progenitors with the help of CD22 or CD24, which is being recommended worldwide. So along with CD22 and CD24, we have to use other markers that are the LAIP markers. So what are LAIP markers? LAIP markers are leukemia-associated immunophenotyping markers, which are classically aberrantly expressed in abnormal B blasts. So the abnormal B blasts can be identified with the help of LAIP markers in the MRDs. So what are the LAIP markers which are used very broadly worldwide? So there is CD73, there is CD81, CD58, CD123. CD73 overexpression is seen in abnormal B blasts. CD81 downregulation or dim positivity is seen in abnormal B blast. 58 overexpression is seen in abnormal B blast, and CD123 overexpression is also seen in abnormal B blast. So apart from that, we can use CD38, CD20, CD22. Many other markers can be used, but apart from all these LAIP markers and downregulation of other markers, we have to keep in mind that the primary gating strategy, that is the first step from where we have to start the analysis of MRD, is 19 positive cells. And when the patient has received a blinatumomab, in place of CD19, we can use CD22 and CD24. Thank you.